Hello everybody. Today we are going to discuss about the myasthenia gravis. So myasthenia gravis is the most common autoimmune disorder that affects the neuromuscular junction. It is a treatable disease but can result in significant morbidity and even mortality. This can usually be prevented with timely diagnosis and appropriate treatment of the disease. The age of onset is variable from childhood to the late adulthood, with the disease peaks in the younger adult female and the older male. Myasthenia gravis is the example of antibody-mediated autoimmune disease. It can also be viewed as an example of class 2 hypersensitivity reaction, as Ig antibody react with intra and extracellular antigen, leading to the end organ damage. Crisis refers to the threatened and actual respiratory compromise in myasthenia patient. It may reflect the respiratory muscle insufficiency or inability to handle secretions or oral intake. Now about pathogenesis, myasthenia gravis is an autoimmune disorder of neuromuscular transmission. Circulating antibodies react with the component of acetylcholine receptor within the postsynaptic muscle membrane and activate complement-mediated lysis of muscle membrane, accelerated receptor degradation, and impair receptor activation. The result is fewer receptor that can be activated at affected neuromuscular junction, causing weaker muscular contraction. Electrophysiologic study of myasthenic neuromuscular junction discloses end plate potential that are diminished in amplitude. So this is a diagrammatic representation of neuromuscular transmission in normal individual and in my patient with myasthenia gravis. So we can see the decreased density of acetylcholine receptor and complement mediated damage to the postkinetic membrane in myasthenia gravis patient result in decreasing miniature end plate potential, which occurs with spontaneous release of acetylcholine receptor vesicle as well as end plate potential in response to nerve action potential of presynaptic membrane. So the diminished amplitude of end plate potential in myasthenia gravis resulted in impaired neuromuscular transmission. Now about causes of myasthenia gravis. Myasthenia crisis is precipitated by the infection. The most frequent are respiratory tract infection caused by viral and bacterial agent. Aspiration pneumonia is occur in 10% of myasthenia crisis patient and is more prevalent in patient with oropharyngeal weakness as manifested by difficulty in swallowing, chewing, altered facial expression and disarray. Certain medication exacerbate myasthenia gravis and leads to myasthenia crisis. Uh, these medicines include vancomycin, this aminoglycoside. Other factors which may lead to myasthenia crisis include botulinum toxin injection. Recent surgical procedure like thymectomy and trauma can precipitate this condition. The presence of thymoma seems to be the risk factor for myasthenia crisis. Hypoalbuminemia upon the hospital admission has been associated with severe myasthenia gravis and myasthenia crisis. Several risk factors have been described for postoperative myasthenia crisis, including alcohol consumption prior to surgical procedure, postoperative complications such as atrial fibrillation, pneumothorax, and acute respiratory distress syndrome. About clinical spectrum, the clinical hallmark of disease are weakness and exaggerated muscle fatigue. The specific muscles involved and severity of weakness are highly variable between individual and within the same individual over time. Ocular muscles are more frequently involved, diplopia is common, and various patterns of ophthalmoparesis are seen. Bulbar muscles are frequently affected and leading to varying combination of facial paresis, dysarthria, and dysphagia. Ptosis is common, but pupils are never affected. Limb muscle involvement may vary from very isolated weakness to generalized weakness and fatigability. Myasthenia should be considered in any patient who cannot be weaned from ventilator support after otherwise uncomplicated surgical procedure. Approximately 15 to 20% of myasthenic have only ocular and eyelid involvement. Now, how to detect the patient in crisis? Patient with the definitive diagnosis of myasthenia gravis have complaint of worsening weakness, shortness of breath, and assessed by dysphagia, stridor, adequacy of ventilation. So during examination, the respiratory pattern requires assessment. Rapid shallow breathing indicates the respiratory muscle fatigue. Diaphragmatic function is assessed by observation of abdominal movement during respiratory cycle. With severe weakness, the paradoxical respiratory pattern develop with inward movement of the abdomen during inspiration. The strength of neck muscle correlates with the diaphragm wheel strength, and the weakness of the muscle should alert clinician to possible respiratory compromise. A simple way to evaluate ventilatory reserve is by asking patient to count from 1 to 25 in single breath. Patient with significant limitation should undergo measures of respiratory parameters. Assessment of oropharyngeal muscle begins with inquiries of difficulty swallowing, episode of choking and coughing while eating. A wet and gurgling voice or stridor may indicate the need for intubation for airway protection. Swallowing may be tested by bedside by observing patient swallow 3 ounces of water and monitoring for coughing or choking. However, caution should be taken in performing this assessment and it need not to be done in patient with clear signs of oropharyngeal weakness. Patient may present with the worsening of respiratory status because of vocal cord paralysis. In this patient, the flexible laryngoscopy loop should be performed. A finding of vocal cord in the adapted position should alert physician for possible need of cricothyrotomy in cases that conventional endotracheal intubation is not feasible. The respiratory status of the patient at risk of myasthenia crisis should be monitored closely. Bedside measurement of force vital capacity. That is, force vital capacity normally is more than or equal to 60 ml per kg. Negative inspiratory force normal is more than 70. Positive expiratory force normal is more than 100 should be done serially. ABG is also important and pulse oximetry is not substitute for this measurement. Blood gas measurement are abnormal with advanced respiratory dysfunction. Patient may have normal oxygenation by the pulse oximetry, while arterial blood gases show the developing hypercarbia. It is a sign of impending respiratory arrest. Values of FV's functional volume capacity of less than 15 ml per kg body weight, negative inspiratory pressure force of less than 20 centimeter of water, peak expiratory flow of less than 40 are indication of the intubation. Early mechanical ventilation is preferable to prevent worsening atelectasis. Patient with the low FVC but not to the level to warrant prompt intubation. Those with independent predictor of the MV should be admitted to intensive care unit for serial measurement of the spirometry parameter. Cardiac arrhythmias are common among patients with the myasthenia crisis and are additional reason for intensive care monitoring of patient with myasthenia crisis and evidence of impending myasthenia crisis. Now about differential diagnosis, acute intermittent neuropathy, which is characterized by the asymmetric limb weakness progressing to quadriplegia after several week attacks. Then botulism, nausea, vomiting preceding muscle weakness, blurred vision, dysphagia, dysarthria, descending muscle paralysis, dilated pupil, dry mouth, constipation, and urinary retention. Then ICU-acquired weakness, critically illness, myopathy, patient with COPD asthma requiring mechanical ventilation and use of neuromuscular blocker and corticosteroid. Patient with sepsis, critical systemic illness and transplant patient. Now about electrolyte imbalance, generalized muscle weakness, cardiac arrhythmia with or without rhabdomyolysis. Guillain-Barré syndrome, preceded by the upper respiratory or gastrointestinal infection, ascending paralysis, and areflexia. Lambert-Eaton myasthenic syndrome, symmetrical proximal muscle weakness, hypoactive or absent dependent reflex, dry mouth, blurred vision, and orthostatic hypotension. Now about lead poisoning. Pure motor weakness, initially of extensor muscles, fasciculation, abdominal pain, constipation, anemia, renal failure, motor neuron disease weakness, wasting, and fasciculation. Then OP poisoning, exposure to insecticide, petroleum additives, and modifiers of plastic, followed by acute cholinergic crisis. Then poliomyositis. It is characterized by the proximal symmetrical muscle weakness and elevated creatinine kinase. Then prolonged neuromuscular block. Patient with the impaired renal and hepatic failure who had been on continuous neuromuscular blocking agent. Now about diagnostic studies. The diagnosis of myasthenia gravis is clinically suggested in patients who present with chronic ocular, bulbar and appendicular weakness, variable over time with preservation of non-normal sensation and reflexes. Myasthenia crisis should always be considered in the differential diagnosis of isolated ocular and bulbar weakness. Again, prominent muscular fatigability and temporal fluctuation are key features of the disease. Normal pupil, normal sensation, and normal reflexes are to be expected and are helpful in diagnosing myasthenia gravis when coincident with acute and subacute paralytic illness. Now about endrophonium test. It is fast and the short-acting parenteral and cholinergic inhibitor. It reaches the peak effect within 1 minute after intravenous injection and persists to some extent for at least 10 minutes. Myasthenic weakness typically improves transiently after administration of 4 to 10 mg. The hydrophonium test may be blinded with drug or normal saline being injected. Whether drug or placebo, 0.2 ml test drug toast is given to screen for excessive cholinergic side effects such as cardiac arrhythmia and GI side effects. Resuscitation card should always be available and patient with known cardiac disease and elderly patient warrant ECG monitoring. Interpretation of the test depends on identifying and observing unequivocal baseline muscular deficit that can be improved following injection of endrophone. Ptosis and ophthalmoparesis, if present, the semi-quantifiable and well-suited. If a respiratory compromise is present, monitoring maximum inspiratory pressure and vital capacity is used. As a general rule, positive response are dramatic, and if there is doubt about positivity of the test, it should be considered negative. False positive heterophonium tests are quite rare and false negative are common. Now about serological testing, antibody to acetylcholine receptor. 85% myasthenic have undetectable serum antibodies which bind to the acetylcholine receptor. The sensitivity drops to 70% in those with the pure ocular myasthenia. Presence of antibodies is strongly indication of the disease. It correlates poorly with the severity of disease or clinically responds to the therapy. If test is normal, it does not exclude the diagnosis, especially in patients presenting with predominantly ocular symptom and sign. These antibodies have also been found in small percentage of patients with Lambert-Eaton myasthenia gravis, patient with autoimmune liver disease, and patient with lung cancer without neurological disease. Now, antibodies directed against the musk. 30% to 70% may have antibodies directed against the muscle-specific tyrosine kinase, an enzyme that catalyzes the acetylcholine receptor aggregation in the formation of neuromuscular junction. Musk antibody may reduces the acetylcholine receptor clustering and impair the neuromuscular transmission. Patients who have antibodies to musk are younger women, prominent bulbar involvement, neck and respiratory muscle weakness. It is an indication of severe disease requiring immunosuppressive therapy and a high frequency of respiratory crisis. Anti-low density lipoprotein. 10% of patients with generalized myasthenia gravis do not have detectable antibody to acetylcholine receptor and muscle specific kinds. Patient with thymoma and in those with late onset myasthenia antibodies that react with muscle protein titin and ryanodine receptor. They may help in detection and recurrence of thymoma. They tend to be associated with more severe disease and may help in prognostication. Myasthenic also have increased incidence of other autoantibodies, including antithyroid antibody, antiparietal cell antibodies, anti-nuclear antibody, and routine testing for these antibodies are not recommended. Electromyographic study. Electromyographic hallmark of myasthenia gravis is decrement in amplitude of muscle potential seen after exercise or slow repetitive nerve stimulation. The decrement should be at least 10% and preferably 15% or more. Routine motor and sensory conduction studies are normal. More severely affected patient is more likely to show decrement response. This is the diagram which shows 2 Hz repetitive nerve stimulation of median nerve, demonstrating significant amplitude decrement peaking at 25% on fourth waveform of the trend. Note that the greatest absolute decrement of 14% is observed between first and second waveform, which is a typical for decremental pattern seen on slow rate of repetitive nerve stimulation. Now, the general care in the crisis. We should identify the trigger that should be removed and corrected. All patients should undergo extensive evaluation for infection, including culture of the sputum, urine, blood, as well as other signs as clinically indicated. Empirical use of antibiotic need to be carefully tailored to the clinical situation because the potential for some antibiotic to further impair neuromuscular transmission further as well as development of bacterial resistance. Avoidance of unnecessarily use of antibiotic is further emphasized by observation that C. diff colitis complicate prolonged crisis. Nutritional assessment need to be made early in the course of myasthenia crisis. A determination is made for necessary for short-term nasogastric tube feeding, peripheral hyperelimination, and gastrotomy tube with the expectation that weakness may not resolve quickly. Electrolyte imbalance will compromise neuromuscular function. Close monitoring with appropriate correction is required. Intermittent positive pressure breathing may be useful in preventing development of atelectasis, and if patient is already intubated or with respiratory tract infection, aggressive pulmonary toilet is necessary. Deep venous thrombosis prophylaxis measures should be undertaken with use of compression stocking, sequential compression devices, and subcutaneous heparin. Coagulation status may be deranged from heparin use when plasma exchange is performed, and intravenous immunoglobulin therapy may predispose to hypercoagulation. Gastrointestinal prophylaxis is given either histamine receptor or proton pump or the proton pump inhibitor to prevent stress ulcer and gastrointestinal bleeding. Psychological support for patient and the family is also important with emphasis on the ultimate ability to return most patient to excellent functional level. Ventilatory management. Non-invasive bilevel BiPAP is used for patients with chronic ventilatory insufficiency caused by neuromuscular disorder like muscular dystrophy, amyotrophic lateral sclerosis, and spinal muscle atrophy. It has also been shown to be useful in patients with acute respiratory insufficiency caused by disorder like myasthenia gravis. In one series, endotracheal intubation during episode of myasthenia crisis was successfully avoided in 70% of trials. In this series, presence of hypercapnia predicted BiPAP failure and need for intubation. So, ENLS module for acute non-traumatic weakness recommended trial of NIV as temporizing measure in patients with myasthenia gravis exacerbation who are expected to recover quickly and in whom immunotherapy can be instituted promptly. However, patients with severe ventilatory impairment and bulbar dysfunction should be excluded from the trial of NIV. Once decision of mechanical ventilation is made, rapid sequence intubation should be performed. This entails the masking the patient to obtain arterial oxygen saturation of greater than 97%. Administration of free running intravenous normal saline, continuous blood pressure monitoring, bolus infusion of sedative medication, for example, usually etomidate at zero point 0.2 to zero point 0.3 mg per kg. If short acting muscle relaxant are needed, preferably they are to be avoided. Non depolarizing agents like pecoronium should be used. Oral intubation should be undertaken whenever possible. Once patient is intubated, a mode of ventilation need to be chosen. But there is no perfect selection. The assist control and the synchronized intermittent mandatory ventilation is commonly used and each one with its advantages and disadvantages. Muscle fatigability with the weakness and the poor lung expansibility are main determinant in the development of myasthenia crisis. The initial objectives of the mechanical ventilation should promote should be to promote rest and expand the lung. It was thought that as long as the patient does not have primary lung disease, compromising lung compliance, larger tidal volume, that is 50 ml per kg, combined with lower rate to maintain normal lung ventilation, with positive pressure of at least 5 to 15 could be used. Avoiding peak airway pressure are maintained with acceptable limit. However, the literature suggests that smaller tidal volume, that is 6 to 8 ml per kg of ideal body weight, faster respiratory rate should, that is 12 to 16 breath per minute, should be used to avoid lung injury. Adding intermittent sigh, that is 1.5 into tidal volume, 3 to 4 times every hour to avoid atelectasis. Such a strategy has been called lung protective ventilation, which should achieve lung plateau pressure of less than 30, allowing some permissive hypercapnia. Patients require continuous monitoring of end-tidal CO2 to adjust respiratory rate to level as close as to normal as possible to avoid significant acid-base derangement. About ventilatory weaning, some parameters may be useful in vain to initiate weaning from mechanical ventilation, functional volume capacity of more than 15 ml per kg, negative inspiratory force less than minus 30, positive expiratory force of more than 40, and minute ventilation of less than 50. Other general conditions should satisfy before weaning is attempted. Patient need to be adequately oxygenation with PO2 of mole is more than 60 mmHg, with FiO2 of 40% and PEEP of less than 5. The patient also need to have intact respiratory drive. In patient with myasthenia gravis, respiratory drive may not to be impaired to be able to protect airway and have adequate cough reflex. The hemodynamic status should be stable, electrolyte levels should be normal, nutritional status should be adequate. The patient should be free of infection and other significant medical complications. The need for respiratory suctioning should be less than every 2 to 3 hours. Now about treatment of neuromuscular dysfunction. The therapies may be divided into those that improve strength rapidly with short duration of action and those that improve strength slowly with more permanent response. In first categories, these are acetylcholine receptor, acetylcholinesterase inhibitor, plasmapheresis, and intravenous immunoglobulin. The second categories comprise immunosuppressive agents such as corticosteroid, azathioprine, cyclophosphamide, cyclosporin, mycophenolate, and tacrolimus. The latter are not used in rescuing patients from myasthenia crisis, but in the long-term management. The role of corticosteroid are controversial. So this is the paper which was published in context of oral corticosteroid dosing regimen and long-term prognosis in generalized myasthenia gravis. The conclusion of this paper was low-dose prednisolone regimen with early combination of other treatment option may ensure early achievement of treatment target in generalized myasthenia gravis. Now about cholinesterase inhibitor, which provides symptomatic improvement by means of decreasing degradation of acetylcholine at neuromuscular junction. Continuous intravenous infusion of pyridostigmine is reported as an effective treatment in myasthenia crisis compared to plasmapheresis as measured by mortality, duration, and ventilation and outcome. Its use has been defended, especially when myasthenia crisis is triggered by infection. However, it is common practice to discontinue this agent in mechanically ventilated patients due to propensity for promoting excess respiratory secretion and mucus plugging. Another concern is the reported occurrence of cardiac arrhythmia in myasthenia crisis patients, including those receiving intravenous pyridostigmine. Cholinesterase inhibitor could increase the cholinergic activity at cardiac muscarinic synapse, leading to arrhythmia. So this is the paper which was published in the context of acetylcholinesterase inhibitor in myasthenia crisis. And the conclusion of this trial was, in places where IVIG and Plexin is not available, continuous infusion of pyridostigmine and neostigmine may be used with or without other co-intervention, provided that patient is admitted in intensive care unit and airway has been secured adequately. Caution should be observed using acetylcholinesterase inhibitor because of possible cardiac complications. Plex has traditionally been a preferred treatment in managing myasthenia crisis, with reported efficacy of 75%. Its mechanism of action is related to removal of circulating factor in addition to acetylcholine receptor antibody. There is no standard protocol for Plex. The usual regimen is exchange of 1 to 1.5 plasma volume every day or other day for 5 to 6 treatments. Clinical improvement may be seen as early as 24 hours. In most patients, first effect appear after 2 to 3 sessions of the Plex. Some patients may have initial worsening thought to be due to reduction in plasma concentration of cholinesterase. The duration of the effect is usually less than 10 weeks if other immunosuppressive treatment is not instituted. The most frequent complication of the plaques are hypotension, electrolyte imbalance, depletion of clotting factor, and thrombocytopenia. Obtaining vascular access may at times be difficult, may be complicated by pneumothorax, thrombosis, and infection. When a large volume of plasma is removed, intravascular volume should be replaced with albumin in saline solution. Any electrolyte imbalance should be corrected to prevent exacerbating weakness. The coagulopathy is usually mild but should be kept in mind when utilizing subcutaneous heparin for DVT prophylaxis. Reducing antihypertensive drug dosage and administering intravenous fluid before procedure may avoid hypotension. Another option for specific treatment of myasthenia crisis is IVIG. Standard course consists of 400 mg per kg per day of IVIG for 5 days. Response to IVIG is usually observed 5 days after treatment initiation. There is general consensus that IVIG may be as effective as Plex. However, IVIG may be better choice in patient with hemodynamic instability, vascular access problem, or with poor response to Plex. Adverse effects occur in fewer than 10% of patients. Most commonly include headache, chills, fever, fluid overload, and rarely renal failure. Anaphylaxis may occur to IVIG component in patient with IVIG. Uh, uh, Anaphylaxis may occur to IgA component in patient with IgA deficiency. IgA levels and baseline renal function should be obtained before treatment is initiated. IVIG and Plex are equally effective in treatment of impending and manifest myasthenia crisis. The choice between two therapies depend on patient comorbidities. For example, Plaques cannot be used in sepsis, and IVIG is contraindicated in hypercoagulable state, renal failure, and hypersensitivity to immuno. The use of preoperative plaques is advocated in patients with generalized myasthenia gravis and preoperative symptoms of oropharyngeal and respiratory weakness, or in patients with symptoms controlled by the use of cholinesterase inhibitor in order to prevent delayed extubation and reintubation. IVIG has been used preoperatively, but the variability in reaching maximum response 3 to 19 weeks should be kept in mind. About thymectomy, thymectomy is always indicated in patients with thymoma because of its malignant potential. Thymectomy has been mainstay of treatment for non-thymatomatous myasthenia gravis for over 50 years. However, randomized trial of thymectomy plus versus medical treatment are lacking. Thymectomy within first 3 years of diagnosis may lead to better response. The procedure is commonly restricted to patients under the age of 60 to 65 years because older patients usually have atrophic thymus. Anti-MuSK antibody positive patients tend to have poor response, probably be explained by lack of typical thymus pathology in this patient. There is controversy as to whether minority of seronegative myasthenia gravis patients benefit from thymectomy. So this is the randomized trial of thymectomy in myasthenia gravis. The conclusion of this study, the background of this study was thymectomy has been mainstay in the treatment of myasthenia gravis, but there is no conclusive evidence of its benefit. And the conclusion of this study was thymectomy improved the clinical outcome over 3 year period in patients with non-thymatous myasthenia gravis. Thank you, guys.